We are what we eat, and the potential benefits of what we eat are limitless. Yet, we tend to turn to supplements and prescription drugs when we're seeking to manage chronic conditions towards specific health outcomes. While supplements and prescription drugs provide us with specific usage guidance and predictable results, the foods we eat and have access to can be our most powerful tool if we know which ones, how to use them, and we understand their benefits. Food-based solutions are all around us, which is why Validation Institute is pleased to introduce a new FoodMed certification to shine a spotlight on the good work being done in this area. Our mission is to promote the use of food as medicine in the prevention and intervention of illness by validating proven solutions that enable people to better manage their health through tools and nutritious food programs. We are committed to helping companies and people make informed decisions by providing them with the information about the effectiveness of programs that aid in building food security and in preventing, treating, and managing diseases. By relieving companies of the burden of creating such programs themselves and promoting transparency, we strive to instill more confidence in decision-making, leading to better health outcomes for all. FoodMed, presented by Validation Institute, will be a partnership of leaders from across the food industry spectrum, academia, and healthcare. We invite you to join us in this important, timely, and much-needed mission.
Thank you, everyone. So join me in welcoming the moderator for this event, Dr. Joshua Skeller. Dr. Skeller is the CMO of Avisis, and he will be moderating this event. Thank you.
Thanks, everyone, and thanks to Think 360 and my esteemed colleagues who you'll meet in a moment on stage. Let me take a moment to introduce myself and the organization I represent, and then I'll pass it to my panelists here, and they'll do the same. So I'm Joshua Sklar. I'm a public health physician by training. My wandering career through healthcare has included taking care of patients in a community setting. It's also included working for a couple of academic medical centers, both in a research capacity and a healthcare transformation capacity at Columbia, at Johns Hopkins. I've done a couple of venture-backed startups, sort of transforming healthcare delivery. And most recently, have taken the job as the Chief Medical Officer and Chief Innovation Officer for Avisis. Avisis is an insurance company in the healthcare space that historically has been in a space that would be known to you as supplemental benefits. Traditionally, these are not your primary medical coverage, but they are things like your dental coverage, your vision insurance, hearing coverage, et cetera. Avisis has a new vision for that category of insurance. And essentially, I would summarize that vision in this way, which is to say, what are the things that are essential to people's health and to their health care that really are not adequately addressed or covered by their existing health insurance benefit package? I think there's a tremendous opportunity in this moment to reimagine those components of health and well-being that maybe we could deliver a little better as an insurance industry. To that end, our approach is really to look across the lifespan and to put people first when we think about what folks need to live their happiest, healthiest life. So what do I mean by that? We design benefits from pregnancy to early childhood to adulthood to advanced age. And across that lifespan, one of the themes that continuously emerges as a need is food and nutrition. And that's probably no surprise to anyone here, especially if you showed up for this panel discussion. One of the challenges that we as a payer have encountered right away in the food and nutrition space is there's a tremendous amount of nutrition science out there in the world. There is less in the way of health services research or translational research, or call it what you will, that demonstrates what organizations are faithfully reproducing that nutrition science in the real world at scale measuring the right outcomes associated with their programs, and then actually demonstrating the impact, whether it's on health outcomes or healthcare spending. This is a major challenge if you're a payer looking to scale nutrition and food as medicine interventions. So that brought us to a partnership with the Validation Institute. You'll note the Validation Institute buttons floating around the room. This is an organization that I had worked with at a previous company to validate a home colon cancer screening program, which is to say, does the program, as it is constituted and run in the real world with real people, real members, patients, people in the community, lead to better cancer screening and ultimately better cancer outcomes? Little did I know that one day we would be partnering with Uber Health and Albertsons and Mom's Meals to create a center of excellence at the Validation Institute, specifically focused on food and nutrition, and we're very pleased with the launch of FoodMed Certified and the FoodMed Certified program, which will probably come up in conversation today. But without further ado, I think that's enough about myself and Avisis, and I'd love to pass the baton to Caitlin, and maybe we'll work from that end down, and please introduce yourselves and the wonderful organizations you represent and the incredible work you're doing.
Great. Thanks, Josh. I'm Caitlin Donovan. I'm the Global Head of Health for Uber. For those who don't know what Uber Health is, first of all, I hope everyone took an Uber to get here today, because that makes the explanation a lot easier. But it's not just you pull out your Uber app or your Uber Eats app and use it for healthcare services. We're actually a completely separate web-based dashboard that focuses on 4 supplemental benefits: transportation, prescription delivery, grocery, and over-the-counter delivery. And like Josh was just talking about, we firmly believe that existence of supplemental benefits alone does not necessarily meet patient needs. You really have to think about the way that those benefits are administered effectively, and that's where we spend our time. Not in introducing new benefits, not in changing them, but working with health plans, value-based care providers, and really across the healthcare ecosystem to make sure that we don't waste a good patient touch point and can engage patients where they are to leverage the supplemental benefits that exist across Medicaid, Medicare, and even commercial plans increasingly to maximize the outcomes for patients.
Thanks, Caitlin. Hi, everyone. I'm Irina Pelfrey. I represent Albertsons Companies. We're a grocer located in 34 states and representing banners that you may be familiar with, such as Jewel Osco, Star, Shaw's, Safeway, Vons, Tom Thumb, and the like. Depending on where you live, you may be using us as a grocer. We also have pharmacies in our stores. So our purpose as a company is to bring people around joys of food and inspire well-being. So I think there is no kind of better way to start this conversation and how food can play a role in well-being. And you know, that's a topic that I am personally pretty passionate about. I've spent now roughly 17 years thinking about retail locations as an access point for healthcare. Previously at Walmart, now at Albertsons. Between pharmacy interactions and frequency of grocery shopping, again, your point about touch points, we really need to leverage the access and the frequency of engagement that exists. So we want to create a better system.
Great. Hi, everyone. I'm Catherine McPherson. I'm Senior Vice President of Healthcare Strategy and Chief Nutrition Officer for Mom's Meals. In my role with the organization, I'm a dietitian by training, but I have the pleasure of supporting our product strategy as well as strategic partnerships, any of our pilot programs, which I think we'll touch on today, and a lot of our policy initiatives. So I actually get to spend a lot of time here in DC advocating for broader access and payment for food as medicine programs in Medicare and Medicaid, and doing education with lawmakers, committee members, and other organizations around the importance of food as medicine. But Mom's Meals, we are the largest medically tailored meals provider in the country. So we've been in business for 24 years. We deliver to absolutely any address in the US, including Alaska, Hawaii, Puerto Rico, Virgin Islands. We are healthcare partners. That's where we got our start in Medicaid, and today we partner extensively with Medicaid, Medicare Advantage organizations, value-based providers. We partner with hospitals, health systems, community-based organizations, hospital-at-home programs, anyone who needs a medically tailored meal delivered to the home. Our meals are all therapeutic, so if you need a renal specific meal or a pureed meal or diabetes friendly, et cetera, we'll have that. We are a mission-driven organization, so our mission is improving life through better nutrition at home. And as I said, we've been doing that for 24 years. We partner with every large national payer, and it's been great to meet with some of you here today. Many regional payers, and again, we are proud to be that healthcare partner and help to build food as medicine programs as they evolve over time. And with that, we are innovative as well. So not only the medically tailored meals, but what else do members need that our partners are looking for? And that includes things like produce and pantry boxes, which we provide. We have telephonic nutrition or dietitians who provide nutrition education. We integrate with the healthy food cards that are a popular supplemental benefit today. So, we're always looking for new ways to innovate, and a lot of times that takes partners to do it. So excited to be here with some partners on stage to speak with you all.
Well, as you can tell, we have an incredibly experienced panelist group ranging from nutrition experts, technology executives, grocery and pharmacy leadership. So I'm very excited to prompt this group to talk about a few really important topics. And the one I'd like to start with is, this is an exciting moment for food and nutrition in healthcare. I think there's this growing realization that food and nutrition are vital to good health, and they haven't always really been a vital part of healthcare delivery or health insurance benefits, and that this is the moment when that can really begin to change. But it's also a moment I approach with a lot of trepidation, which is to say, food and nutrition has been essential to people's lives long before healthcare sort of intruded into that world. And I'm curious to hear each of your perspectives on where individuals are as consumers on their food and nutrition journey and how they think it interacts with their health today, what solutions they're already implementing, not just seeking, but doing in their daily lives without healthcare's sort of intrusion. I think one of the things that's particularly valuable at having this group of people is that, when I was a doctor, I thought about patients, and now I'm in an insurance company, I think about members. Patients and members, it turns out, are quite different populations, and neither really is quite synonymous with consumers, people writ large. And I think we probably have hundreds of millions of consumers evaluating and using the services of your organizations every day. So that being said, a long preamble, what do consumers want from us when it comes to incorporating food and nutrition into their healthcare? And what are they already doing today? Where are we starting from on this journey? Caitlin, I don't know if you want to take an initial stab at that.
Sure. Josh, I loved the way you put that, of how healthcare is now intruding on consumer behavior. And I think one of the things that we need to think about as a group and as an industry are, what problems are we trying to solve? We use the term food as medicine blanketly, and I'm not sure that that allows us to hone into the individual need of a patient, a member, or as a consumer, as you so eloquently put it. And in my mind, the issues could be threefold. One, you don't have access to food physically. You might know what you need to get, but you might not have a way to get there or to pay for it consistently. Two, you might not have the appropriate education to know what you particularly need for your specific disease state, condition, et cetera. Or three, some combination of those things where you don't know how to navigate the tools at your existence that already exist to maximize the dollars you have, the nutrition at your disposal, et cetera. And to Catherine's earlier point, I don't think we solve that as an industry without partnership and thinking through the way consumers behave today. So just to describe our point of view here, when you think about what a health plan typically does when they offer a supplemental benefit is they file the benefit with CMS and then publish it in member handbooks and then expect their members to go through all of the details to find out, how do I access this benefit? Where is it available? Without considering the behavior of that member as a consumer. And I think that's what we can all do together, is recognize that we have touch points with these members, with these patients, with these consumers that fit the daily patterns of their life, that allow us to not intervene, but enhance the actions that they're already taking, versus give a member homework to solve the real problem they have. So to give a really concrete example here, our whole philosophy at Uber Health is don't make a member have homework. Don't make a patient have to add one more thing to their to-do list. Don't make someone who has food insecurity figure out where they can find the funding, the means, the way to get there. Interact with them in the way they already engage with the world. I think the way you do that is through a combination of technology, understanding your consumers, and having the right partnerships. So in our case, our technology is location agnostic. You can meet members truly as consumers because you can meet them where they are, whether it's at the pharmacy at Albertsons, whether it's at the call center where they're trying to request their mom's meals, or whether it's at their federally qualified health center provider's office that allows them to tap into the benefits right then and there without giving them 5 more numbers to call. And so I think thinking about that consumer journey versus the traditional, I filed the benefit, let me wash my hands of the matter, is the way that we'll be able to address some of those problems at the individual level, but still in a way that scales.
Yeah, I think we're really guilty in the insurance industry of neglecting the difference between being eligible for a service and actually getting people to avail themselves of that service and hopefully benefit from it, which says very easy and does very hard. Irina, I would love to hear your perspective on that same topic because, embarrassingly, I don't know how many people are walking into an Albertsons brand grocery store on a weekly or monthly basis, but I know it's a very big number. And it seems like such a great opportunity to direct people on a food and nutrition journey, a food as medicine intervention. What can we learn from the grocery store shopper and their lives and their shopping experience as we try and bring healthcare's imprimatur to nutrition?
Yeah, Josh, great question. And Caitlin, consumer-centered design is always the answer, I think. But to your specific kind of statistic, we have about 66 million households going through our doors or engaging with our e-commerce platform within a given year. 21 million of those households have someone living with a chronic disease, diabetes, hypertension. So if I take my healthcare hat off and just think about it as a grocery customer, 3 themes emerged from our own research. One is education, nutrition education. 2 is agency. Sometimes eating the right foods actually takes effort, even if you know what to eat. And then 3, it's affordability, which kind of ties into benefit coverage and finding benefit coverage. So from our perspective, solving those 3, again, through whether it's digital tools, in-store shelf labeling, other educational materials, we can help our customers in a tangible way, even if healthcare stakeholders don't step in. But luckily they are stepping in. So from our vantage point, we're thinking a lot about simplifying nutrition labels. There's obviously a standard that's established for food labeling. There's USDA guidelines. There's dietary guidelines for Americans, but from an education perspective, everyone is at different reading levels, comprehension levels. People are often strapped for time, translating a nutrition label into something on the go as they're making their shopping list or as they're in the store. It takes time, and not everyone has it. So we want to think about the cognitive load that it takes for, let's say, taking someone newly diagnosed diabetic. The first question is typically, what can I eat? I need to change my habits. What can I eat? And how do we make it taste good? In those cases when a benefit is available, where a medically tailored meal is available to you through the plan, that's amazing, right? With delivery included, but not everyone is that lucky, right? Most of us still have to go through the store and make those decisions. So part of kind of the most accessible benefit right now in the space, you mentioned, Flex Card or spending cards. Our objective in improving affordability is to make those accessible and inform customers that sometimes they have that benefit and they don't know about it. It's very prevalent in Medicare, now becoming more consistently available in Medicaid. I think commercial space is a little bit behind, but I do see that as also a really strong retention driver, potentially, because food is the type of supplemental benefit that everyone understands. So yeah, these are some of the insights that we kind of gleaned from our consumer research and focus groups.
Well, Catherine, I would love to ask you about this in particular, the topics of accessibility and retention. You're at an organization that is serving up probably the most accessible intervention I can think of. It's a medically tailored, nutritious, ready-to-eat meal specifically for you that shows up at your home. Mm-hmm. You're doing it at scale. I can think of no more accessible solution. And I'd love to hear you talk a little bit about the impact that has on utilization, the kind of utilization that we're all sort of craving as payers, which is that high-value, prevention-oriented utilization, which we never get enough of, as opposed to the downstream utilization that occurs when that doesn't happen. Tell us about the Mom's Meals solution and the data points that really indicate how compelling it is for people to have that meal show up at their home.
Yeah, happy to. I think you hit on it there. People want convenience, especially if you think about, I would say the most common medically tailored meals benefit in Medicare Advantage today is the post-discharge benefit. Mm-hmm. It's very prevalent. 69% of MA plans, 71% of D-SNP plans offer this benefit today. This is a benefit where somebody discharges from the hospital. Imagine that's you. You're coming home from the hospital. You've just had, you might have had something with your heart, you might have had something elective, but you're coming out, it's stressful. There's a lot of follow-up after you leave the hospital. You might have had some new medications that you have to go and fill, and you're not up on your feet yet. You might not be able to drive, you might not be able to lift a grocery bag, you're not supposed to be on your feet for long periods of time. So, a fully prepared meal that you just put in the fridge, take out and microwave for a minute and a half, that shows up at your door, it tastes great, it's appropriate for your chronic conditions. That is the kind of convenience that people need, and it can help drive the kind of results that we're looking for in food as medicine. So post-discharge meals programs typically provide 2 to 4 weeks of support after discharge for an inpatient stay to prevent that readmission. We see readmissions reductions both in published studies and a lot of the case studies we do with our own health plans who want to test their benefits through claims data. It's a 25 to 50% reduction in readmissions for people who are getting the meals. So that's really incredible and really compelling, and it's a very short-term ROI, which is why it's such a common benefit. What we are looking for is, and you asked about utilization as well. Utilization really depends, and Caitlin touched on this, on the operations at the health plan. So the product team often files the benefit. That goes in their bid. It goes to CMS. it doesn't stop there, as you said. So, there need to be a lot of meetings, and we like to facilitate those meetings as well, sharing best practices from other implementations across the country, to meet with the clinical team or the teams that are reaching out to people after they discharge. Or if you have a maternal health program or a diabetes management program, those could be people in the community, it could be in Medicaid or Medicare. Whoever is member-facing, we want to provide training and sharing of best practices to make sure that those operational steps are documented in a workflow and everyone kind of knows their role. The health plan is investing in these benefits. They do really want to see good utilization. They're bought into the ROI. The members, when it shows up, the meal comes, somebody calls, offers the meal, yes, they just say, this has been a lifesaver. We hear that directly from members themselves. We hear that from caregivers who are the ones kind of, scheduling the doctor's appointments, getting the prescriptions, et cetera. It's just one less thing on their plate. So I would say members want convenience, and I think the utilization depends on kind of that partnership between product and operation at the plans. Kind of one more point I wanted to make is, how do we build a continuum, that includes the groceries, it includes the healthy food cards. Post-discharge is just the tip of the iceberg. I've been that dietitian in the hospital that says, I'm chasing someone down the hall with a piece of paper that says, here's your low-sodium diet, don't forget. And it's the last thing people want to hear, and change is hard. These aren't the foods I'm used to eating. I don't know how to cook like this. I've got a million other things on my mind. And we need to make it sustainable. So you can start someone out if they're newly diagnosed, if they've had a discharge, if they're food insecure. Let's change their food environment. Let's provide for their needs and get them started on a program to help with that behavior change. Exposed to new foods, people report that they're sleeping better. They typically see an immediate drop in blood pressure. A1C goes down. We see this with about 12-week programs. We see weight loss. People are getting positive feedback from their care team, like, what are you doing? This is great. But then how do you maintain that change? So the steady state for some people, if they have physical limitations, it may be meals. The steady state for most people is not that way. It may be a meal a day. I mean, how many of us cook 3 meals a day from scratch? Right? We're all going to kind of, put something together and eat, or heat and eat. And that could be a steady state. It could be 1 meal a day for somebody on an ongoing basis, where they're filling in with an easy-to-prepare meal from semi-prepared or with scratch ingredients that they get at the grocery store, or that are supplemented if they need that from their healthy food card at their health plan or from their employer. And I think you touched on that. The commercial market has started coming around, but we are really excited to launch our first large diabetes program with a large employer in Ohio just a month ago. So, again, I think as we build out relationships with health plans, kind of the Medicaid had the benefits first, that moved into Medicare Advantage, and they're having conversations with their commercial colleagues about sort of the great impacts of the program, and we are starting to see more interest on the commercial side, so that's been wonderful.
Yeah, I'm sure we're all thinking the same thing right now, which is what a seamless transition would look like from discharge at the hospital to your medically tailored meals are delivered for 2 weeks, 4 weeks, whatever the case may be, to how to make those same meals for the next 2 months, 3 months, 4 months, when you go to Albertsons, where to shop, where to find those ingredients so that you can get a more durable behavior change, and not just your 30-day all-cause readmission risk goes down, but your 60-day, your 90-day all-cause readmission risk goes down. But that exciting vision immediately raises one of the topics that I have to ask everyone about on this stage, which is, what are the barriers to scale that your organizations face? I mean, everyone up here represents a fully scaled solution here. Millions of medically tailored meals being delivered safely to people's doorstep, tens of millions of people walking into a grocery store, hundreds of millions of people use the Uber platform. I'd be remiss if I didn't ask you, what are the barriers that you face in your everyday work lives to scale when it comes to food and nutrition in the healthcare space?
I actually think Catherine just touched on it really well, which is, what is the appropriate behavior at the right time, and how do you optimize for that in the way that you plan your design? And I think about how to optimize behavior in three ways. One is, what is the specific intervention that that person needs at the right time? I think Catherine said it so well. It often starts with a meal, and then there's almost an off-ramp to a combination of meal, grocery, et cetera, depending on the specific individual. Two is, how do you physically access what you need? Whether that's you're driving to the grocery store, you can pick it up, there's delivery service for you, aided by technology, or you just going off a handwritten shopping list. And then third is, how are you gonna pay for it? What's the combination of tools that allow you to make sure that you can take that effort sustainably? And so when we think about scale, we think across all three of those dimensions. One, we've made sure to integrate a full marketplace versus just a grocery store, just a medically tailored meal provider, to make sure that you can optimize for the individual patient with that same repeatable behavior. Second, from an access standpoint, we've made sure to be engagement point agnostic, whether that's a patient accessing directly, their care coordinator accessing on their behalf, and that care coordinator's purposely vague term. That could be social worker in the home health worker, the pharmacist at Albertsons that helps you check out, call center to health plan, et cetera. Same view for the entire care team. And then third, that I think we don't often talk about, especially when it comes to supplemental benefits and food as medicine programs in particular, is coordination of eligibility and benefits, which is the really boring back end that really matters when you might be getting some funds from your Medicare Advantage program and some funds from your employee assistance program that's dedicated to caregivers. And so thinking through how we build to scale that, which is what we call our member management platform that allows you to coordinate benefits across all funding sources, we think is critical to make sure that you have that appropriate protocol for you via marketplace, omni-channel engagement points, plus the coordination of funds.
Caitlin, I like how you laid out kind of the continuum. I want to maybe double click on kind of how a grocer would view the problem. And for us, one of the barriers to scaling is actually in the coordinated care space. And I'm really excited about the marketplace that you're launching and look forward to continued partnership there. A grocery store doesn't know how to bill employers, Medicaid, or Medicare. There is no infrastructure, there is no claims processing, eligibility verification system. Pharmacy may know how to do all those things, but we're not billing a pharmacy benefit. So when it comes to care that's coordinated through caseworkers, maybe a little bit more complex disease states or populations that require coordination of multiple benefits, transportation, food, et cetera, those are tricky to scale. Just even the task of, imagine your normal e-commerce ordering experience, right? You put in your grocery order, Uber delivers it, everyone is good to go. Imagine that same process done through a caseworker. Caseworker arranges delivery time with the covered member. Then grocery store picks the products, Uber delivers it, but there's a triangle of communication that needs to happen, both for the claim to get paid and for the member to have a really satisfying experience and not feel stigmatized because they're covered by a certain type of plan. So to me that is one of the most important benefit design and to some extent policy issues right now.
I have to ask about one particular aspect of scale that vexes our insurance company, and I think really every insurer, which is scaling engagement. And I ask that because each one of you really has a very unique lens on engagement, I'd imagine. One of you, engagement is I engage with Uber through an app. It's an app on my phone. I engage with a Safeway or an Albertsons by physically entering the space and shopping there, probably on a routine. I probably engage with Mom's Meals because I got told to, or AKA an order from a physician at discharge, or I got told to by my insurer, or invited to at least. This is a perennial challenge for health plans, especially we're very heavily invested in the Medicaid space. We serve millions and millions of Medicaid members every day. So what does the engagement scaled, the fully scaled engagement solution look like at your organizations? What's really working today? I get that food and nutrition is itself more engaging, say, than certain other things we're trying to get people to do in healthcare. But given that tailwind, what then is really working for you, Catherine?
Again, I think it depends on how the clinical team is touching base with the members that have been identified for the meals program. So after discharge, case managers typically reach out and coordinate care for members and ask about needs from, again, DME to meals to follow-up appointments, providers. So if there's robust post-discharge outreach, but we're talking scale here, and we have seen, I would say, a decrease in case management teams, the size of teams and outreach over time at health plans. We have seen an increase in community health workers, for example, in Medicaid. So it's people who are in the community and provide, face-to-face touch points within their community, which has been fantastic to see. So community health workers are now covered benefit in California. There's a 12-week medically tailored meals benefit in California, along with medically tailored groceries, along with other nutrition programs and other community supports in California that's covered for all Medi-Cal beneficiaries who have a chronic condition or a high-risk perinatal condition. So, it's just wonderful to see enhanced case managers, community health workers reaching out and being able to tap into these robust benefits. So I think that when states are let's talk Medicaid first. When states kind of come together and say, what resources are available, how can I bring this together and make it a scaled model across the state, building multi-stakeholder work groups prior to launch, continuing to check in along the way and make adjustments as needed. I think that we can see, fantastic partnership to drive that scale. When I would say, let's talk Medicare Advantage now, when there are compressed resources from CMS that everyone's dealing with, and you don't want to remove care or supplemental benefits or increase premiums, so what's there to do? There need to be some efficiencies that are created or benefit changes, and we have seen that. And so, a live touch point after every call might not work. And so we do rely on technology. There are a lot of engagement platforms, probably some folks here, just making members aware of what's in their benefits plan so you don't have to access your handbook, or just, having that presumptive authorization. So if anyone discharging from the hospital can benefit from meals, just presumably have those meals show up. So we can streamline to really scale benefits where they make sense and there's just not the clinical resources to reach out and make a live touch point. And I think those partnerships with engagement platforms and other folks like that can really make that fruitful.
So, Irina, if the community health worker and the case manager at a health plan or even at a health system, a hospital system, is that really powerful engagement lever for a mom's meals, what's the case for an Albertsons being an extension of that network for health plans? Because, as Catherine mentioned, health plans tend to have fewer and fewer of those people every day, it seems, and we're all looking for alternative models. And it seems to me that Albertsons enjoys a really trusted relationship with its shoppers and a pretty consistent one. Can you tell us a little bit about that?
Yeah, so I would look at this issue kind of from two dimensions. One, we think omni-channel, right? So we think in-store interactions. It can be pharmacist, it can be technician, kind of in more of those acute situations where medication is involved. That can be a point of information delivery and workflow. Maybe you came in for, to pick up your refill, but we can, at that point, intervene and relay a message on behalf of the plan. The second piece would be digital. So within our e-commerce platform, we actually added a new benefit for customers that's available to anyone, which is essentially a digital engagement platform specifically focused on wellness. It's called Sincerely Health. So within that, we're actually measuring ourselves like any tech company would. We're looking at monthly active users. We're looking at actual engagement rates and NPS, with a goal of really setting a high standard. Unfortunately, that's higher than health plan NPS and engagement, so that we can then take those best practices and merge the two of the worlds. Traditional consumer world with really high bar on execution and engagement, and then healthcare world where there is a lot of complexity, but they can come together. So that is how we think about it. But then once the customers are engaged, and another piece, part of what Sincerely Health is about is actually behavior change. So if you think about, Catherine might know a lot more about that, but if you think about our relationship with food, it's quite complex, right? We think, about food for nutrition purely, but it's also every celebration has some kind of food. Grief moments have food. Of course, those challenging healthcare transitions may be good or bad in terms of what food you intake. So behavior change is difficult. So we want to help customers kind of outside of those acute moments with that behavior change. And we actually do it with rewards and coupons toward healthy groceries. So that's an important point to this whole discussion too. Just because you cover a food benefit, it doesn't mean people will eat it. So Catherine, probably in your experience, cultural preferences are really important, right?
They are.
Taste profile, ability to filter on allergens or ingredient preferences. Those are things that make food enjoyable. So part of the trick in designing a really successful and scalable benefit is also to impact behavior change as part of it, which leads to higher engagement.
Yeah. I think omni-channel is the word of the day here. And it comes back to how Josh started this panel around, we think of people as patients or members and not really as consumers. And our whole philosophy is you have to meet people where they are. Otherwise, you're not going to be able to influence their behavior change because you've already made them do something that's out of their comfort zone to get what they need. What I've observed about health tech in particular is too often that technology company assumes that they're going to have the best patient experience and engagement point, and so they want to own the full end-to-end experience. And the impact of that, especially for complex chronic members and patients, is that they end up with 20 different apps that they have to use. That's not a great way to engage people. How can you get more out of a single interaction is so critical to what we do. And that's why from our standpoint, yes, we all know and use the Uber and Uber Eats app, but much more critically important, especially for those who've been newly diagnosed, who just got discharged from the hospital, who have a case manager, how do you take that interaction and make it more fruitful to drive the right action, not give the member homework, and enable the behavior change right away, and do it so that you can make it easier for the repeatability. Candidly, that's why Uber Health is not typically a consumer-facing app. It's web-based, provider, care coordinator, case manager facing, so that we can connect that care team on the back end, so no matter where that engagement point is, the patient gets what they need.
Maybe just to build on those comments of Caitlin's as well, I think starting that journey can be a challenge.
Yes.
And Irina touched on that as well, that change is hard. And, getting people on that easy path to begin is really important. And a lot of the programs that we work within with our health plans have telephonic disease management. That's just a standard program that exists. And what we did see in one of our recent programs, and we love to share broadly the results from these great programs. We try and present as often as we can at national meetings, hold webinars, just to share those best practices. But one of our recent case studies showed that the successful call completion rate or engagement rate for telephonic disease management was 11%. When meals were added, that immediately doubled, more than doubled, it went to 24%. So they were like, I can't believe this is great. And the length of time that somebody stayed engaged with their nurse went from, even though the meals program was only 8 weeks, people stayed engaged with their nurse previous to the meals was 6 months. Like maybe you get a call here, you'd miss a couple months, you get a call there, 6 months max. It went out to 18 months where people were actually picking up the phone when their nurse called. So they saw it as a huge success. So it was a great way. 8 weeks, started somebody out, they got engaged. We saw medication adherence improve in that program. Resources from the community were available. This particular plan didn't have the grocery card benefit. But they were linking to members to other resources in the community, but they did stay engaged with their health plan and their nurse throughout that. So again, meeting someone where they're at, meeting their needs down the line, but knowing how to engage them up front is really important, and that fully prepared is just convenient. Also something that's immediate value to people who are struggling to manage a complex chronic condition like diabetes or heart failure or renal disease or a combination of those. And many of the folks that we're supporting, they're Medicaid, they're dually eligible, et cetera, but they're vulnerable in many ways and are often food insecure, and so they just don't have time to focus on their personal well-being.
Yeah, one of the things I think that as an industry, healthcare is quickly going to realize and make the pivot to is it's not just food as medicine, it's food as engagement.
Yes.
Because I think it's incredibly resonant for people and compelling in their daily lives. That being said, just a minute left. I wanted to ask each of you as we part for one suggested piece of reading. It can be on this topic or off this topic. It can be related, but something that everybody in the audience who's in healthcare should read. And since I'm putting you on the spot, I'll go first. I'd highly recommend everyone Jeffrey Rose's landmark paper, Sick Individuals and Sick Populations. Jeffrey Rose was a British epidemiologist and kind of the founder of the strategy of preventive medicine. And I think that paper is incredibly relevant because the central point is for us to move the needle on the health of a population, we have to choose interventions that address the whole population and not just the sickest few that really drive the costs. But I'll quickly put each of you on the spot for one piece of recommended reading as we make our way out.
Oh gosh, Josh, really putting me on the spot. I'm now forgetting the name of the piece. Milliman ran this study about supplemental benefits in general, and it really speaks to Catherine's point about thinking of them not only as MLR reduction, but as engagement tools. And of course, as soon as we get off stage, I'm going to remember the name, but it's Milliman. Yeah.
Fantastic.
I think on the topic of kind of validated studies and a tie-in to FoodMed Certified, the Milken Institute just published a really good resource on food as medicine, scaling it from a kind of multi-stakeholder perspective, what it will take for it to become a scalable benefit, over time with actuarial support. So really good resource, check it out. And it's also linked in the FoodMed Certified website as well.
I'm going to refer folks to the momsmeals.com website for our white papers. We have several out there, so if you're interested in a food as medicine program, check those out. But also a wonderful book that I just read. If you are interested in social determinants of health and want to hear more of a firsthand perspective, it's called The Emergency, nonfiction book written by an ER doc on the south side of Chicago during the pandemic, and struggling to serve his community through the pandemic, and it was just a fantastic read. So The Emergency, look at that one.
Well, thank you. You've been fabulous panelists, and thanks to the Think 360 team for helping us put on a wonderful panel discussion. Please give my guests here a round of applause as we depart.